The job has become untenable in some ways. You don't just take care of the patient who comes in and presents with a problem. I have back pain, I have a sprained wrist, or whatever. Then you're asked to take care of all the patients who don't even come in, but who are a part of your community or part of your population. The one physician model is just not going to work where one physician does it all. It takes a team.
I'm J.B. Wogan from Mathematica, and welcome back to On the Evidence, a show that examines what we know about today's most urgent challenges and how we can make progress in addressing them. On this episode, we're going to talk about the primary care workforce crisis, a complex, multifaceted problem made all the worse by the COVID-19 pandemic. The crisis, as my guests will explain, is about more than simply a mismatch between the supply of primary care service providers and demand. It's about retention, burnout, pay, not attracting enough providers in the right places, not having enough diversity in the field, and more. We have excellent guests to guide this conversation. Luci Leykum is a general internist who was involved in the creation of a report last year from the National Academies of Sciences, Engineering, and Medicine that looked at ways to strengthen the primary care field. That report builds on the recommendations of a 1996 report by the Institute of Medicine by providing an implementation plan for high-quality primary care in the United States. Luci is also the Executive Associate Chair at the Department of Internal Medicine at UT Austin's Dell Medical School, and she serves as the Center Lead and Principal Investigator for the Elizabeth Dole Center of Excellence for Veteran and Caregiver Research for the Department of Veterans Affairs through the South Texas Veterans Healthcare System. Sue Lin is the Deputy Office Director of the Office of Quality Improvement within the Bureau of Primary Health Care at the Health Resources and Services Administration, better known by the acronym HRSA. She also helped get sponsorship for that National Academies report we'll be discussing. Julie Schilz is a Senior Director on the Clinical and Quality Partners team at the Primary Care Development Corporation, which recently published a data brief on investing in primary care to achieve better health and equity in the United States. Aside from her current role, Julie is a registered nurse by training, and she brings that perspective to the conversation. Diane Rittenhouse is a family physician by training and a senior fellow at Mathematica, where she co-authored a report for the California Healthcare Foundation that reviewed evidence that could inform health policies aimed at increasing the size and diversity of the primary care workforce in California. I should note that if you want to learn more about this topic after the episode, Mathematica is also co-hosting a Twitter chat later this month on June 23rd from 2 p.m. to 3 p.m. Eastern Standard Time on challenges and opportunities for the primary care workforce. You can find that chat as well as past Twitter chats about primary care using the hashtag #PrimaryCarePolicyChat, all one word. If you have questions for our guests, both Julie and Diane will be participating in the chat and would be happy to answer any burning questions that we didn't get to in this conversation. A full transcript of the episode, along with links to any research we reference in the conversation, will be listed in the episode's show notes and on a blog at mathematica.org. I hope you enjoy the conversation. So we can jump right in. Luci, I keep seeing headlines about the primary care workforce crisis. Sometimes the story focuses specifically on the workforce shortage, but in preparing for today's conversation, I've learned that the problem is multidimensional. Would you mind kicking off this conversation by briefly describing, or rather briefly defining the problem? What is the primary care workforce crisis?
Sure. Thanks for that great question. I think on the simplest level, one way to describe it is that more people are leaving the practice of primary care than are entering the field. And let me give you some numbers to sort of help define what that looks like. So I'll start speaking from the physician perspective. About 10 years ago, in 2010, there were almost 250,000 physicians in the U.S. who were primary care physicians, according to the AMA. Now, 10 years later, we've lost about 20% of that workforce from physicians. It's just over 200,000. More than 50% of physicians report burnout, and that number is from 50 to 70% in primary care specifically. In the last 2 years, even more attention has been paid to this issue, and 1 in 5 primary care physicians are thinking about leaving practice in the next 2 years. Besides thinking about leaving practice, a large number are going part-time. That's sort of the leaving aspect. And then when we look at people coming in, physicians coming in, we see more people choosing non-primary care specialties coming out of medical school. So fewer people going into family medicine and internal medicine. And pediatrics, a little more stability there. Within internal medicine, 5 to 10 years ago, 50% of internal medicine residents went into primary care. Now that number is far less. More people specializing, more people going into hospital medicine. These are multifactorial problems, but the numbers certainly are concerning. And when you look at nurse practitioners, the numbers of nurse practitioners going into primary care has increased, looking at nurse practitioners who are graduating with primary care training. But that rate of increase has actually slowed over the last 5 years as well.
Diane, I want to turn to you now. Beyond the increasing number of overall workers, and this gets back to this idea of the nuances of supply and demand and whether it's just we don't have enough. Besides just the number of overall workers, how do the geographic location, demographics, language proficiency, cultural competencies of primary care workers factor into concerns about building up the pipeline of future primary care providers?
That's a great question, and those are all really important points. I think that the overarching issue that we often think about is shortage, but there's also geographic maldistribution, and there's the mismatch between who's practicing primary care and who needs a primary care clinician in the population. And so, for example, in California, 40% of people in California are Latino or Latinx, and 7% of physicians are Latino or Latinx. So there's just a mismatch there between the population and the cultural background of the physicians in training. There's also a tendency for people to go into practice. We have a lot of residency programs in urban areas. A lot of people will stay then in urban areas, and we have a hard time drawing primary care workforce into rural areas without some real good thought about the pipeline. So we know that there are some ways to increase the chances that someone will end up in a rural area, but without concentrated thought and policies, we see physicians grouping in urban areas, and there's an underinvestment and the primary care specialties are under-resourced. And so for clinicians to choose to practice in primary care and take care of the underserved, to go to an urban underserved area or a rural underserved area, often they will have to be paid less when in fact the demand is higher for physicians and clinicians in those areas. So the market doesn't exactly work in terms of the workforce for primary care physicians.
Before we move beyond just defining the problem, I want to make sure, is there anything else that our listeners should know about the current crisis? What's in your mind when you're thinking about what that phrase primary care workforce crisis means?
I would just underscore the geographic variability issue. It is orders of magnitude difference, 5 times as many, 10 times as many primary care clinicians in urban areas versus rural areas.
I was fishing around. I found a website that it looks like it's produced from HRSA. they were projecting that by 2030 there would be reduced supply for rural areas for, I think, internal medicine providers, and there would be increased demand in rural areas. And I believe it also showed increased demand in urban areas, but still and increased supply, but not increased supply to keep up with the demand.
Yeah. So. And JP, I think you're talking about our health workforce research center
yes.
that supports those projections. I think the crisis that Diane Luci spoke about was a strong impetus for HRSA to support and be a co-sponsor on this National Academy of Science report, implementing high quality primary care and rebuilding the foundation of health. Fundamentally, we have to be able to support primary care, and then in our space, primary care safety net programs, and support an environment where young professionals can feel and identify where they can thrive and commit. As many of our clinicians that joined the National Health Service Corps have dedicated decades of their career to this profession and supporting the underserved community. So recognizing the crisis, but we also hold on to what can we optimistically effect change at the national and federal level to make things better moving forward.
I'm glad you flagged that report because I do want to discuss that. In fact, I wanted to reference it in my next question. My impression is that the pandemic has made obvious why change is needed in how we invest in primary care in this country. And I was struck by a quote from the report last year on primary care from the National Academies of Sciences, Engineering, and Medicine, which I think maybe we can just refer to as NASEM if you want, or the National Academies, something more shorthand going forward. But the report makes the argument that primary care should be treated as a common good. And to quote from the report, it says that responsible public policy requires that a common good, be it public education, grazing grounds for farm animals, or the capacity of primary care to meet the needs of a population, merits some degree of public policy for oversight and monitoring. And in the absence of that, the good is depleted and not available when the need for it increases. Such has been the case for the primary care during the COVID-19 pandemic. And that's the end of the quote. So, Julie, did the pandemic simply reveal problems that already existed in the primary care workforce, like that our public policies don't treat primary care as a common good? Or would you say that it exacerbated the pre-existing crisis?
I would say that it exacerbated the previous crisis. And I think Diane mentioned the crisis in the workforce underscored that primary care is under-resourced. And we kind of alluded to the concept that we've been underinvesting in primary care, and we haven't looked clearly and consistently at how we can invest in primary care in a variety of ways, and these are all outlined in the NASEM report, about how we use a variety of policy mechanisms as well as payment mechanisms to pay primary care so that primary care can have teams of individuals working with them to be able to deliver care to a variety of patient populations. But you asked me, JB, about how the pandemic really surfaced many and exacerbated many of the elements of the workforce crisis. And one of the things that happened is that primary care had to change on a dime because of what the pandemic was doing. So the pandemic really meant that primary care had to change how they were delivering care, changing from seeing patients in person to seeing patients virtually. So when you have to make those changes and you have very limited staffing to be able to do that, it makes it even that much more difficult without those resources of people resources to be able to change the way you're delivering care. being able to engage your patients in a different way. So that's just one example of how when you have the limited resources, you're kind of managing your patient population on a shoestring as it is, and then you have a pandemic that you're not in a position to already know how to manage and needing to then change the way you deliver care and manage from that perspective day in and day out without any respite. So I think, Luci, you had mentioned the burnout that happens from that.
Part of that whole we need to change how we're delivering care became a real reliance on non-face-to-face interactions with virtual care, more telephone care. And in some ways that's been a real plus, but in some ways that's actually been a problem because not all patients can access those modalities for care delivery. And generally there's been a lot of discussion about worsened health disparities during the pandemic. And that access to digital health has been part of it. And primary care clinicians have been on the front line of sort of experiencing that difficulty. And I think there's been a real sense of moral injury among primary care clinicians in terms of not being able to take care of patients equitably, not being able to provide the types of supports that are needed that has really worsened the burnout. And when we think about the level of chaos in people's lives during the pandemic, and just the number of mental and behavioral health issues that were really exacerbated across society by the pandemic. Julie talked about how primary care was sort of operating on a shoestring and barely able to, in a lot of places, provide the holistic care that clinicians want to provide. And when more and more of your patients have more and more of those health issues and life issues, again, that just makes it really hard, really challenging for primary care clinicians to function. They feel like they can't meet the needs of their patients. Their own lives are more chaotic. Their own kids are also not in school. And it really just truly created a perfect storm of inability to practice the way we want and inability to really balance the work-life aspects of practice that came together.
And as Luci mentioned, as we think about the pandemic and as we're entering into a different phase within the pandemic now, but primary care will be dealing with the effects of long COVID and what does that mean and how will the symptoms of long COVID impact the patient population and change care delivery from that perspective, and how will that impact the needs of their patient population, and what will the differences be related to different patient populations, urban versus rural, and those are some real consequences of COVID that will be long lasting. So while some of the initial phases of COVID will be coming through and there will be a time where we can say the pandemic is over, there will still be long-lasting impacts for primary care that they will be dealing with.
The COVID-19 pandemic presented unprecedented challenges for our health centers that are in the medically underserved communities. I think in 2020, we learned that 1 in 8 health center staff tested positive for COVID. On average, it's about 7% of the health center staff unable to come to work. And then at the peak, it was, more than 10%, 14%. And then, with the availability of vaccination, health centers were not just called to support public health mass testing efforts, also vaccination efforts. And then I think in the process of us trying to figure out how to support the health centers, we stood up a vaccine logistics distribution process that we had never really encountered before at HRSA. So working with CDC, we got an allocation of vaccines that then were really focused on the special populations that we served in the agricultural worker population within our legislation, individuals experiencing homelessness, residents of public housing, and then patients with limiting with proficiency. So I really think, just given the level of engagement and then the call from, states, departments of health centers to assist in this public health emergency, we need to be very thoughtful as we go into the recovery phase, especially, Julie mentioning long COVID. There's so much for us to figure out and learn and how health centers, primary care overall is going to need to be in the community support the patients that we collectively serve in the COVID recovery.
Your comments remind me of one of my close friends from college. He works in internal medicine, and I remember him feeling a little frustrated that a lot of the media coverage early on in the pandemic was casting a positive spotlight on those who work in emergency rooms and urgent care, but maybe not lifting up those in primary care who are playing a really important role in combating the pandemic. And it's interesting the interplay of primary care and public health and the parallel conversations happening there around rebuilding the infrastructure in both fields and how the two need to cooperate and be more integrated.
Collectively, we are primary care champions participating in this podcast. The best chance for patients to be safe in their community is for our primary care to thrive, right? That's how our clinical providers can keep folks safe and not overwhelm the hospitals and ICU beds as we saw during earlier parts of COVID.
And that will only be successful if primary care and public health are integrated, and as you mentioned, JB. And I think that when you take two sectors, if you will, that are chronically under-resourced and kind of never quite given what they need to do their job well, that's primary care and public health. And then you put a stress on that when primary care was already suffering from burnout, already suffering from not enough people going in, already geographic maldistributions, et cetera. And you take public health that we sort of tend to ignore, and it tends to have sort of anemic budgets and not enough support because we like to think, well, as long as everything's going well, we don't want to think about public health and we don't want to finance it. And then you take those two and you want to integrate them to support something like a pandemic. At the beginning of the pandemic, primary care doctors couldn't even get protective gear. They couldn't get payment to see patients online. They weren't part of the program in terms of responding to the pandemic. And what we've learned is how essential it is to have your primary care clinicians talking to patients to help, because they have those trusted relationships and they can actually go that extra mile to help patients understand the science, for example, and make sense of what they're hearing in the news and whether or not it's safe to get a vaccination and what a vaccination might or might not help them with, and why they're being asked to stay at home or why they're being asked to wear masks. Or a lot of that explaining lands on the primary care doctor or the primary care team that has trusted relationships in the community.
Diane, I want to stick with you. We've been talking about problems, but this podcast doesn't just stop at problems. We try to surface evidence-based solutions or things that could make things better. And you co-authored an evidence review for the California Healthcare Foundation last year that looked specifically at the primary care workforce crisis in the state of California, and using past research as a guide, looked at what could help address the crisis. So based on your research, where could policy changes make a positive difference?
Thanks for that. We were asked by the state government in California to provide some evidence to help them with their policymaking decisions. There actually had been a commission for the future health workforce in California, which is a very high-profile commission a couple of years ago that was both private and public, and came together and made a bunch of recommendations about how to better support the health workforce in California. Some of the things that, or the question that still remained after that report was published was, well, where do we put our first dollar? If we had a huge budget surplus the last couple of years in California, and it's clear that investing in the health workforce not only helps health care and could improve health outcomes, but can help the economy of the state of California. And if we work with the educational sector, we can really make changes to prep the health workforce for the future. They wanted to know, well, where should we put our money? We have all these ideas, but we just don't know where. And so we reviewed the evidence, and it was a bit of a mixed bag in that the answer was a little bit all of the above. which may be dissatisfying to someone who wants to make a quick decision. We found that there are interventions that you can do at the high school and college level, which are typically called pipeline interventions, because they really start early on, and we were looking at the professional health workforce. So these are people who have to go through many, many, many years of school and training to come out as health professionals at the end. And health professionals is really where we don't have a diverse workforce or a language concordant workforce in California. So we were specifically focused on the health professions. And when you start at high school and college, you have an opportunity to gather a diverse group of people, to bring in people who speak other languages, and to have the workforce pipeline better match the population. Then there's opportunities for scholarships, and the state and federal government can provide scholarships to college students, to graduate students, and people in training, which helps decrease the burden on someone coming from a more disadvantaged background, for example, and ease that path, because people will say, I cannot go into that field. I cannot become that sort of health professional because I am hearing that it will cost me so much money for training, and I just can't make ends meet, given that I'm either helping to support my family or I come from a background that doesn't have the resources. And so just the idea of the cost will scare people away, and scholarships can help with that. Then there's specialized training tracks and programs where you can bring people into graduate school from certain areas of the state. You can teach them with certain emphases, saying, we're going to have a rural track program, or we're going to have an urban underserved program, we're going to have a Spanish speaking track. So you can really expand the training capacity in those particular tracks within the training. And then once people get out into practice, you can pay off their loans, so there are some really great loan repayment programs. The question that was posed to us is, well, which of these should we invest in? And our answer was a little bit, well, it depends on what you're trying to achieve. And you can't only invest in one or the other. You need to sort of invest along the pipeline, because if you pay people to go practice in a certain area, or you pay off their loans to get them to go practice in a certain area, that works to some extent in the short run. But if you want to diversify the workforce, the professional workforce over time, or you want the professional workforce over time to become culturally competent or language concordant, you really need to invest in those early programs and support those students all the way through their training. So lots that can be done, and good evidence that supports it, but it's not only a short-term solution. There are also long-term investments that need to be made.
Diane, I think that part of that work and the history that your research helped to support really is part of a legacy, particularly in California, that has just created such wonderful momentum that continues even today to continue to support primary care and bringing, the state and multiple stakeholders together in California. And it really focuses on looking at what other states are doing as well. So the NASEM report really created a lot of energy, but there are other states, Oregon and Rhode Island, but it's creating a almost virtuous cycle within other states. And we got news that in New York, they just passed legislation to start a primary care commission that is intended to then move towards looking at further investments in primary care. So I think these efforts built on research and evaluation and some of the policy levers that can be supported by all of these efforts really help to support and the continued momentum and efforts and movement. But to your point, which ones are the right ones? Sometimes we say all healthcare is local. So I do think it depends on what the dynamics are and what is the right levers to pull within a state. But your work was quite foundational, I think helped to drive the work we're seeing today in California.
Julie, could I pick up on one thing you just said? So you mentioned some states like Rhode Island that are investing more in primary care. And I imagine some listeners might be thinking that the direction we should be going in is simply that we should all be, every state nationally, we should be spending more on healthcare, or at least more on primary care. And so I wanted to put this question to you and maybe to others in the group. How should listeners think about the current level of investment in primary care and the allocation of dollars for primary care services? Is it just a question of more, or is it about spending smarter or in different ways than we currently are?
Yes to all of the above. I think when you look at where the level of spending is at within your state, it's a matter of where are you at now. What my organization has done is looked at New York. It was around 5 to 6 to 7%. And if you look at the research, and in some cases comparing it to some of the states that have increased spending within primary care, and then you're comparing that to other costs, then you can look at where should we be at and know that we're getting better outcomes and value with our increased primary care spending. So I'm hedging a little bit on what the right number is, because I think you have to look at your data, you have to look at your patient population, and you have to look at where might the right investment be. But the number of around 5%, generally speaking, seems to be a level that suggests there's an opportunity to do a higher level of investment and have better outcomes in your patient population.
Just to pick up on that, it is 5 to 6% of the spend nationally, and it's 30% of the activity. So there is a huge mismatch between spend and activity. And when we look at the places where we're spending money in the acute and post-acute settings, a lot of that spending could be mitigated if there was more investment on the primary care side.
Luci, to stick with you, you were part of the committee that released that report from NASEM last year on implementing high-quality primary care. And the report included a chapter on preparing the future primary care workforce. So sticking with this idea of some solutions, what were some of the committee's high-level conclusions and recommendations around training the primary care workforce of tomorrow?
Yeah, on the highest level, it's really saying we have to train people in high-functioning primary care settings that reflect and are integrated in the communities that they serve. And there are a lot of bright spots out there with regard to primary care that could be models for what this looks like. And, when you look at some of the characteristics of those settings, true team-based care with expanded teams that can take care of the whole patient, and adjusting the workflows to minimize unnecessary administrative work that's such a key part of burnout. And more specifically, the NASEM report pointed to two things. So first, expanding and diversifying the primary care workforce, particularly in areas that are underserved, which I think picks up on what Diane and Julie were talking about, but more diverse trainees that really look like and are embedded in the communities that they serve. There were some recommendations about what team structures look like, with a core team that includes patients, families, and caregivers, an extended healthcare team that includes community health workers, behavioral health, pharmacy, dental, social work, all the professions that make most sense based on the community being served. And then in this expanded community care team that brings in the other services that are relevant in each community. And really what this is saying is we need to move from a physician-based model to a team-based model, really, one that reflects the community. And then, by doing this, we'll allow learners and trainees to have really authentic team-based experiences that make them want to work in this setting, which leads to the second specific recommendation around CMS VA and HRSA, redeploying and augmenting how they currently fund residency training. So much of that funding goes to hospital systems, and a lot of those hospital systems have expanded and include primary care services, but it's not quite the same as real community embedded primary care. And so, how can we redeploy dollars to go to actual primary care sites and not hospital systems? And how can we make some of those funding sources more consistent from year to year? Sometimes states do have initiatives that will only be around for 3 years, and training programs need to have more sustained funding than that to really invest in that workforce. So those two recommendations around expanding and diversifying the workforce in really authentic community settings and changing the funding to support those training locations were the two recommendations in the report.
You anticipated my next question, which I was going to ask specifically about the relationship between creating interprofessional primary care teams and these issues around burnout and shortages in the field. Is there anything else to say here? Julie, I know this is a priority of your organization is greater integration in primary care. How might burnout be addressed if there were bigger teams or teams that work better together?
Yeah, I think we've learned about this as we've started to look at care delivery models such as patient-centered medical home or accountable care models. And it's also been the structure of federally qualified healthcare centers or community healthcare clinics and in their structure. And historically, there was an idea that the physician had to do everything to be able to deliver care. But as patients' healthcare needs became much more complex, we learned that utilizing the team, and as we really helped support physicians to be able to care for their patients. And we added technology in the process as well. So the team-based care delivery also provided that support as well, and utilizing a team to be able to really become that support entity, not only for patients and their families, but for the physicians as well. But I do think, as you think about federally qualified healthcare centers, the idea of integrating care, whether it's behavioral health, mental health, and as we move to addressing social determinants of health in communities, or adding oral health as well, even starting to think about vision care, really creating a care delivery that is structured to be supportive of patients and their families in the community is how we will deliver healthcare in a way that truly delivers health versus fragmented care delivery that is structured to be fragmented and a very difficult system to maneuver.
I'm remembering there's a part of in the NASM report where they're defining high quality primary care, and the report emphasizes sustained relationships or sustained partnerships, and it explains that these relationships include families and communities, and I think it also includes more than just physicians. It envisions nurses, nurse practitioners, perhaps social workers. So that was educational for me as somebody who's coming, not a healthcare professional, not a physician, learning about how we define primary care now and what our vision should be for the future.
So back to the problem is the job has become untenable in some ways. It's become a job where you don't just take care of the patient who comes in and presents with a problem. I have back pain, I have a headache, I have, a sprained wrist or whatever. You are being asked as a primary care practice to address not only the people with the conditions that they present with, but all of the conditions they don't present with, all the screening, high cholesterol, or screening for diabetes, or screening for breast cancer, cervical cancer, et cetera. And then you're asked to take care of all the patients who don't even come into your practice, but who are a part of your community or part of your population, and bring those patients in for screening or interact with them in some way to improve overall population health. So we're moving towards that, but the one physician model is just not going to work where one physician does it all. So it's really this movement towards, it takes a team. It really takes somebody who has expertise, like a pharmacist, to help someone go through their medications and get rid of medications they no longer need, or medications that are causing side effects or interactions that are problematic, or you need a social worker for the patients or the populations who housing is really their issue, or food insecurity is really their issue. You may need an MA to help contact all of those patients who have diabetes but have not been coming in for care, et cetera. So it really is this team effort that I think the NASM report emphasizes. And the FQHCs across the country, the federally qualified health centers, have really been standout in being able to address issues in that way. And I know Sue Lin could really speak to that.
To stick with the solutions theme in the second half of this episode, what federal policy levers are being used or could be used to build back the pipeline of primary care workers? And to tack on a couple additional questions that are related, but maybe you'll have to tackle them separately. How can we do it in a way that is inclusive of different demographic features, language proficiencies, cultural competencies, and why might greater inclusivity be important for higher quality care?
Yeah, JB, thanks for the question. And Diane, thanks for the comment on the health centers and the patient-centered medical home transformation. I think, we tackle this on a federal level so in the NASM report, they identified 5 key areas, right? Payment, access, workforce, digital health, and accountability. In our space, we feel the call to action to engage in all areas, even if it's not especially under our legislative authority to do so. In the payment space, the report is clear that, we're moving towards value-based care, but negotiating and partnering with our colleagues at the Center for Medicare and Medicare Services on how that design will mean for health centers, will mean for primary care is critically important to us. And, we are just excited that, in their most recent report on looking at the innovation strategies that they want to implement, that health equity is a key focus, and federally qualified health centers and rural health clinics are part of that innovation strategy. On the access piece, access is a core to the mission of our Bureau of Primary Healthcare. And so in designing our funding opportunities, we continue to have that as our guiding principle and North Star in getting access to primary care to communities that have not had access to primary care before. The workforce space, I think Diane's report really, really articulated the different strategies that we have been trying to support across the country with National Health Service Corps, Loan Repayment Program, Nurse Corps, having a health workforce connector where health centers can post positions that then can be open to anybody who's looking to serve in medically underserved communities. And so we have not let any possibility for partnership unturned in this process. And I think in the digital health space, we knew that at the time, when folks were deferring care in 2020 pandemic, that we needed to somehow figure out a way to support bridging the digital health divide in some way. And so I think, in terms of making investments, we have been very, very privileged to put some investment to pilot with nearly 500 health centers to support them hypertension control with remote monitoring during COVID. And some of the health centers, even in very rural Alaska, is showing incredible success for that. I think in terms of moving forward, I will say that I tend to be an optimist. For us, we are launching a workforce well-being initiative and it's for all of the workforce across the health center. So we know that the patient experience begins as they enter into the health center and then all the way into the exam room. So it is front of mind for us to support all of the workforce across the health center, all 250,000 FTEs. I think, we want to be able to understand further what well-being will look like for our health center staff, and then, support with training and technical assistance, and then rapid deployment of promising strategies and practices to get this support to our health centers. I think I've talked about sort of the levers, federal agency collaboration. I think the NASM report and activities that the Office of the Assistant Secretary of Health is leading the effort in that process. So that's something that we're really excited to be a participant in. And then I think, in the workforce area, I think we need to think beyond HHS to also think about how Department of Labor, Department of Ed, can be another federal partner in this process. And then I think, how can we be inclusive of the different demographic features and cultural competencies in our health centers? I will say that in the COVID response, I've had the opportunity to meet some amazing community health workers that some have went door to door to talk to patients, talk to their families about what is the COVID vaccine, and provide just excellent health education for what they're doing. And we call our vaccine program the last mile program because our touch base is over 70% racial ethnic minority that have received vaccination through our program. And so that entire team, based care from community health worker, pharmacist, social worker to medical assistants, dental assistants, everybody that is supporting primary care integration in our clinics are critical to all of the supports to creating a wonderful patient experience. So I think for us, where we sit, we want to continue to support, we want to continue to invest in different demonstration quality improvement programs to help us to learn what will really, really work for our collective health center program across the country. But we're trying out a lot of different efforts. And I think the state models that we see are incredibly informative that Julie alluded to. So I will say that, I previously served in 2 state governments prior to joining federal service. I'm a huge believer that a state-based initiative serves as a blueprint for what we can adopt at the federal level. And so that those innovations and those programs that are implemented at the state level are critically important for us to learn and what we can implement at the federal level.
They're the laboratories of democracy, right? So you've already kind of started us down this path. The last question I wanted to ask was, where do you see progress happening in addressing the primary care workforce crisis? So you already identified a few different areas where I think people would have reason to feel optimistic. Is there anything else you would want to flag for listeners?
Every primary care physicians I meet and the team members, they care about everything and everybody. And so, to be called upon to address the hardest problems that we have facing our community, facing public health, it's something that, I think, every passionate primary care physician that I've ever met has always said yes before there is even resources. But I think it's really important for us to figure out the resources to sustain that and to build momentum to really, really improve the overall population health, and just would invite everybody to be fully engaged in that dialogue and collectively think through what can we do together.
Thank you, Sue. Luci, let me turn to you and put the same question to you. Where do you find signs for optimism? Where do you see progress happening in strengthening primary care?
Yeah, I think there's 4 different areas that we could think about in terms of reasons for hope and optimism here. And the first is that there are lots of examples of success. So despite, what we were talking about in terms of the overall picture looking concerning, there are lots of examples of bright spots where you see really robust and vibrant primary care practices that are really well integrated into their communities and where people are flourishing and there's not a lot of turnover. And so I think that as a field, people are becoming more aware of the bright spots and thinking about how we can learn from them. So that's sort of area number 1. The second is that there's continued evolution in reimbursement. And, for many of us, that's not happening fast enough. But the more we move away from a fee-for-service, piecemeal reimbursement for primary care to something where there's a more global payment that actually supports all the infrastructure and activities for primary care, The more we do that, the better. And in fact, that was one of the key recommendations also in the NASM report, to really change that reimbursement methodology for primary care more quickly. And that's happening. The third is that we have made progress generally in implementation science. And that's really this field of how do we take things that work in one setting and apply them to another. And so that is what helps us really learn from those bright spots as we're more and more aware of them, to say, okay, this works in Alaska, or this works in Boston, or this works in Colorado. How would we put it in our local context? And what are sort of the key themes that we can learn from their success that would work for us here? And we're better able to do that. Finally, the professional societies are becoming much more actively engaged and involved in this issue of burnout because it's such a key issue for their constituents across the professions. As one example, the AMA, the American Medical Association, has actually made this a major initiative in terms of combating physician burnout. And they are developing assessment tools that practices and health systems can use to assess themselves and benchmark how their clinicians are doing compared with clinicians across the country, to say, oh, we're in more danger here, or, oh, we're doing some things and they seem to be having a positive impact. And part of those assessment tools get pretty granular to say, okay, what are the parts of the workflow that aren't working for you? What things would you change? Where could you see improvements? Again, so organizations can really say, like, okay, here are some things that we need to do, and then we can learn from each other for how to do that well. Lots of reasons for optimism.
It may be a funny thing to say that something negative during the pandemic could also be a reason for optimism, but I'm curious, do you think that the pandemic and the problems that were made more obvious during the pandemic have raised the profile of the primary care workforce crisis and put it on people's radars as something that needs to be addressed in a way that it hasn't, at least in recent years?
I do think that that has been the case, and probably across many of the health professions, not just primary care. Now there's a much greater recognition of the general nursing shortage in the United States, for example, as a result of what's happened with COVID. The impact on primary care has been so dire that that has been getting more attention. And it does seem to be getting some policymaker attention. So, for example, the fact that like the telehealth and virtual health regulation changes have been continued, I think is a sign that people are hearing we need to work differently in primary care, as an example. And the other piece that I think is making this more apparent is just the mental health impacts on people and the recognition that the only way that we're going to be able to really successfully engage with people to help them be more healthy and feel better is to do it in the context of their communities and lives. And the only way that's going to happen is in primary care.
Well, certainly, I think primary care workers are not the only ones that have been experiencing burnout during the pandemic, and perhaps that has created conditions or an environment where you have a more empathetic public who understands what it's like to be feeling burnt out in your job and needing some more resources and supports.
Yes, hopefully we're all a lot more empathetic about each other.
Same question, but to you, Julie. Help us end on a hopeful note. Where do you see progress happening?
Well, I think Sue Lin mentioned just the cross collaboration. I'm seeing that on the federal level like I haven't ever seen before, but I'm also seeing just such an openness, whether it's in a local community, whether it's across different disciplines, as Diane mentioned, between primary care and public health, whether it's state up to federal level, whether it's one state with another state, different disciplines talking among each other. There's a true cross collaboration to focus on delivering quality care and really moving upstream, thinking about social determinants of health, supporting primary care, moving from a after the fact disease process focused while we're taking care of individuals from that perspective, but moving to prevention and wellness and community-focused care. And I think that's just an incredible focus on health and health in communities that I'm seeing.
Diane, take us home. Where do you find optimism? Where are you seeing progress?
Well, I'm sitting in the most populous state in the country, and we have an enormous budget surplus. And so, what I'm pleased to see is the investment in health and wellness across the state. And when it comes to the primary care workforce crisis, I see investments in behavioral health counselors for youth, for example, in a new community health worker program. I mean, some of these elements of the workforce are relatively new, not necessarily licensed, not necessarily certified, and it isn't exactly clear how the primary care team is most efficiently laid out in particular settings. And I see experimentation with that. I see a willingness to invest, at least at the state level. I see willingness to invest in new residency programs for primary care physicians, especially in areas of the state where there haven't been them in the past, where people can then train and stay close to where they trained. So I see an openness to and an awareness of the problem that I haven't seen in the past. And a lot of credit in California goes to the foundations and philanthropy that funded the Future Health Workforce Commission and really got some of these ideas off the ground and created some momentum so that the state could then move to act.
Thanks again to my guests, Sue Lin, Luci Leykum, Julie Schilz, and Diane Rittenhouse. And thanks to Rick Stoddard at Mathematica, who produced this episode and made us all sound so good. Finally, thank you for listening to another episode of On the Evidence, the Mathematica podcast. As I mentioned at the top of the episode, a full transcript of the episode, along with links to any research we referenced in the conversation, will be listed in the episode's show notes and on a blog at mathematica.org. Mathematica is co-hosting a Twitter chat later this month on June 23rd from 2 p.m. to 3 p.m. Eastern Standard Time on challenges and opportunities for the primary care workforce. If the topic of this episode hits close to home, please consider participating in the Twitter chat. You can find that chat as well as past Twitter chats about primary care using the hashtag #PrimaryCarePolicyChat, all one word. Stay up to date on the primary care Twitter chat, as well as future episodes of the podcast by following us on Twitter. I'm at JB Wogan. Mathematica is at Mathematica Now.